discuss flaps and its application in plastic surgery. This is the outline I'll be working on. By way of introduction, a flap is a unit of tissue that is transferred from a donor site to a recipient site while maintaining its own blood supply. It's important to note that this differs from a skin graft, which is transferred from a donor site without its own blood supply to the recipient site. Tissues that could be transferred include the skin, subcutaneous tissue, fascia, muscle, bone, or viscera. Flap surgery is a subspecialty of plastic and reconstructive surgery. A good understanding of the reconstructive ladder and principles of flap surgery is key to knowing when to raise a flap and in minimizing possible complications that could result from raising a flap. It is an important skill at the disposal of an experienced plastic surgeon when padded or durable cover of a wound defect is needed. The word flap originated from a Dutch word known as flappe, which means something that is hung broad and loose and fastened by one side. Flap surgery dates back as far as 600 years before Christ, and it started in India by a man whose name is Sushruta Samhita, where he described nasal reconstruction using a pivotal cheek flap. It is said that he is the father of plastic surgery. French first described advancement flaps as well, and in the 1980s, the number of tissue types increased significantly. That's the other tissue types that can be used in flaps, like the bone, the fascia, and the muscle. The key differences between grafts and flaps. The graft is limited to transplantation of just the skin, which could be full thickness or split thickness transplant. And while flaps carry other tissues, like we said, you can carry your subcutaneous tissues like the fascia, the muscle, bone. Grafts are dependent on the recipient site for nutrition, while the flaps have their own blood supply. In terms of cosmesis, your grafts may discolor or contract, while flaps give a better color take and are less likely to contract. And grafts are less adaptable to weight bearing, while flaps are more adaptable to weight bearing. And grafts are less able to survive on a bed with questionable nutrition. For example, if you have a bed that has bone without periosteum on it, or like when there's an implant and there's no source of blood supply on the bed of the wound defect, a graft is less likely to survive there. And flaps can be used on a bed with questionable nutrition. And grafts require pressure dressing to anchor them to the recipient's bed, while flaps do not require any pressure dressing. The reconstructive ladder is a concept of plastic surgery that arranges options of surgical reconstruction from the least complex to the most complex. And it is important to know that the least complex option at the foot of the ladder may not be the best in every scenario. For example, let's say you have a patient who has sacral pressure injury and requires reconstruction of the wound defect that is left. Because of the sacral bone there and the fact that you need padding, closing by the options close to the foot of the ladder may not be the best to use. So it's better you raise a skin flap, which provides a durable and padded cover, like we said earlier. A brief anatomy and physiology of the skin. The skin is divided into two layers. We have the epidermis and the dermis. So the microcirculatory system of the skin is composed of two circulations. We have the superficial plexus, which is also known as the papillary plexus, and it is in the superficial dermal layer, which is the papillary dermis here. And this papillary dermis superficial plexus, it supplies the overlying epidermis by means of diffusion, while the deep vascular plexus in the dermis, known as the reticular dermis, is located here as well. And these arteries arise from branches of the aorta that either perforate the muscle, known as muscle perforators, or from the fascia of the muscle. Some possible physiological factors that affect flap survival include the blood supply to the flap through its base, formation of new vascular channels between the flap and recipient bed, known as inosculation, perfusion pressure of the supplying blood vessels, and neovascularization of the flap usually occurs between 3 to 7 days after transfer. This vascularization occurs through two processes. It could be by direct ingrowth or inosculation, which is anastomosis between the surrounding recipient capillaries and the pre-existing vessels that accompany the flap to the recipient site. Flaps can be classified using the 5 C's of classification. First of which is circulation, based on circulation. So if the vessel that supplies the flap if the name is not known, it is referred to as a random flap. And if the name of the vessel supplying that flap is known, it is referred to as an axial pattern flaps. So most of the skin flaps that we raise are random flaps. While for axial pattern flaps now, they have named vessel. So and based on the components, again, classify the flaps. So if it's just skin, it is referred to as a cutaneous flap. If it is fascia and skin, it's a fasciocutaneous. If it is just fascia, it's a fascial flap. If it's muscle and skin, musculocutaneous. If it's just muscle only, it's a muscle flap. If it's bone and skin, it's an osteocutaneous flap. If it's just bone, it's an osseous flap. Based on contiguity. Okay, so flaps could be local. That means the flap is raised adjacent to the wound defect that needs to be covered. It could be regional, moved from an adjacent region in the body. It could be distant, that means it's moved from a remote area to another area. It could be pedicled, that means it's moved with intact tissue to bridge for support, or it could be islanded. There is no interskin but moved under the skin for non-contiguous effect. It could also be classified by a method of transfer. It could have a simple advancement flap, could have rotation, transposition. In transposition, the site is usually repaired by skin grafting, while in rotation, rotation can achieve the aim of covering the primary wound defect and the recipient site as well. And it could be pedicled as well. Conditioning, this is an old concept that used to be used in the olden days, and the aim was to increase flaps safety by enhancing its axiality, and it used what we call the delay phenomenon, and it's classically done by cutting down on either sides of the flap to be raised. So what is the delay phenomenon? It is any pre-operative maneuver that results in increased flap survival. Maneuvers include things like placing a cutting lint under the flap to prevent its reattachment. That's in the first surgery, and subsequently in the second surgery, I think the cutting lint is removed. Or ligating the vessel supplying the axial flap 2 weeks prior to flap transfer. The proposed theories to explain the delay phenomenon include things like, number one, we have the increased axiality of blood flow. That means if we remove the blood flow from the periphery of the flap, it promotes development of axial blood flow from the base of the flap. And tolerance to ischemia. Less tissue necrosis occurs after delay because it is believed that the flap has been conditioned to undergo hypoxic stress. Sympathectomy vasodilatation theory, which says that dividing the sympathetic fibers at borders of the flap will result in vasodilation and improved blood supply. We also have intra-flap shunting hypothesis, which there's sympathectomy that we've seen. It dilates arteriovenous anastomosis, which are believed to shunt blood, thereby bypassing the capillary bed, which results in no exchange of nutrients. If delay phenomenon is done, there's less sympathetic fibers available in the second surgery, which results in less shunting of blood. And we also have hyperadrenergic states. Surgery is known to be a hyperadrenergic state that results in release of catecholamines like your epinephrine or epinephrine, and these are potent vasoconstrictors. So the level of these vasoconstrictors are believed to reduce in the blood in the second surgery relative to the first surgery. Principles of flap surgery. So there are 5 principles which we follow, which is the replacing like with like. The second is to think of reconstruction in terms of units. And the third is to always have a pattern and a backup plan. The fourth is stealing from Peter to paper. And the fifth is never forgetting the donor area. So for the first principle, which states that we replace like with like, goal is to mask the reconstruction as much as possible. But if there's a you can't get what was lost there, it's best to replace it with the next available thing. For example, now let's say a patient has a defect, a wound defect in the beard region where hair is growing. You could take scalp hair, scalp skin, and put there to cover the defect, as an example. And the next principle, where we think of reconstruction in terms of units, it says that the body is divided into seven main parts according to Millard: the head, the neck, the body, and the extremities. With each part divided into units, and with each unit having its own subunit. The importance of this is that each unit interacts with another with a natural border, which could be like a crease, like we have on our palms, and it could be margins or angles like the jaw and hairlines as well. So it's important to be aware of these natural borders. Number three is to always have a pattern and a backup plan. Well, it's best to weigh options using the reconstructive ladder as a guide. The fourth is to steal from Peter to pay Paul, and this is only when Peter can afford it. This is just to say that you take from the donor site to the recipient site in a way that it does not cause morbidity for the donor site. And for the fifth principle is never to forget the donor area, and which is if reconstruction of the primary defect is too costly, we have to reevaluate and use another method and explore other options of reconstruction. Possible complications that could occur from flap surgery include reaction to anesthesia, reaction to blood products if there's transfusion ongoing as well. Could also have early and late complications. Early complications include things like bleeding, surgical site infections, seroma formation, hematoma formation. Late complications include things like superficial skin necrosis, a partial or complete flap loss, donor site infection. To prevent these complications, adequate preparation, planning of the surgery is encouraged. There are pictures of an anterior lower limbar ulcer here that was covered using a local transposition flap, and the donor site was repaired by a split thickness skin graft. We also have a middle-aged female with albinism who presented with multiple lesions on the face. The lesions were excised and sent for biopsy, and the defects that were left were trapezoid or rhomboid flap that was raised to cover the wound defect that was left here. We also have this patient who was involved in an RTA and had a facial avulsion injury. So we did an advancement flap from the lateral aspect of the cheek, hydradenitis suppurativa, involving both axillae and the perineal region. The lesions were excised and it was closed using a flap that was raised from the infrascapular region behind and skin grafting to cover the residual defect. This is the flap that was raised and advanced to come to the anterior chest wall and cover the defects. Then we had split thickness skin grafting done to cover the residual defects here. In conclusion, the role of flap surgery in reconstruction requires prior preparation, and it should be patient-based, using the reconstruction ladder as a guide, and adequate knowledge of an anatomy of the region of the body involved is required.
What guides the choice of this area of skin to be used for a flap?
So the choice will depend on the defect, the wound defect, as you mentioned. It will depend on patient factors and then the reconstructive options available, as well as the expertise of the surgeon. The wound, you want to know the size of the wound, what is exposed. Is it vessel? Is it bone? Is it a cavity that you need bulk? Or you just need a thin flap to cover? It's a shallow defect. Then what is the surrounding skin? What does it look like? Because your local flaps are the ones that are sharing boundary with the defect. So if you've seen the defect, the size of the defect, and then you now start checking your options. So that's for the wound defect now. Is it infected? Or if the local tissues there are not supple, and for instance, you need a rhomboid flap to get, so that will make you not to choose it. The patient factors, is the patient fit for a long surgery? Maybe you want to do free flap. Patient is not fit for it. Patient has comorbidities that are not controlled. Then the reconstructive factors are now the options that you want to use as well as the expertise of the surgeon. You may say, oh, this one would it's a free flap and you cannot do a free flap. You not do that. You do what you can. You do what you do. Either using the reconstructive ladder or choosing from reconstructive toolbox.
An optimal, or what's the typical lead period, and if there are any factors that influence the timing?
Yes.
So the optimum time, 12 to 14 days, should not be more than 3 weeks. Because whatever gains you intend to have will start losing it, will start declining from after 3 weeks. Yes, within 12 to 14 days, actually should elevate the flap and then use it for the purpose for which you intend to use it. The delay phenomenon improve the vascularity of the flap to increase the perfusion of the flap so that it will survive. So if you don't elevate it by 3 weeks, you'll lose what you have gained already.
Proper pre-operative assessments. So in this assessment, you're going to do a proper history. You want to find out the history of how it happened. If the patient that has a comorbidity, people that are smoking there's a higher chance of flap failure. You want to examine properly, eradicate infection before you can plan for a definitive cover. Then for patients that have free flaps, there's some other investigations you will do. You want to assess the vasculature of your donor site, for instance, angiograms, use of drains, post-op inspection of your flap.
The axial flaps could either be a pedicled flap or a free flap. Axial flap with the blood vessel attached to the parent vessel at time of transfer. While for the free flap is that the blood supply of it is contained within the flap and you transfer it to a defect where you're going to perform microvascular anastomosis. So sometimes the donor site of that rotation flap may be large and cannot be covered. So you can use a skin graft. You need to do skin grafting of your secondary defect. Local flap is a flap that shares a boundary with the defect. A regional flap is one that is within the same anatomic location as the defect, but not sharing a boundary. While you have a distant flap that is in a different anatomic location with the defect. So flap monitoring of subjective and objective criteria. For instance, that will come in the post of subjective criteria are physical criteria. When you go, you look at the color, the toggle, the temperature of the flap, and then that of pinprick, the bleeding, careful to not injure the pedicle. So those are physical criteria you check out for when you see. So if you put the window, the subjective criteria, the objective criteria you can do transcutaneous oxygen tension. You already know the oxygen tension before surgery. So post-op, you check the transcutaneous oxygen tension. And even also use Doppler ultrasound scan. Do salvage the failing flap, pharmacologic methods, seasonal leeches, in super thin flaps, current trend, tissue engineering, 3D bioprinting that will help to prevent even taking donor sites from the patient, just taking a little and creating a large chunk that can be used to replace. So those are the current trend and then even future trends.
It's generally advocated that patients should actually stop smoking within at least 6 weeks before planned surgery. Comparing flap outcomes for both patients that had stopped and patients that had not necessarily stopped, that it did not significantly change the outcome, even though the patient had stopped smoking for a period of time. But it's generally advocated that they should stop at least 6 weeks before surgery. Generally advocated that patients should stop smoking at least 6 weeks to 2 months before surgery. But there has also been some, even patients that had stopped smoking even 2 months before, that they still developed complications. Like smoking on its own already counts the patients out. So it's better for the patient not to smoke at all.
But for smoking, because the problem the smoking is causing vasoconstriction. In free flap, it's not an absolute contraindication for free flap. It's a relative contraindication.